Radhe Radhe to all, and I hope everybody is doing perfectly fine. So, today we'll be discussing is a case of subareolar breast abscess in a 45-year-old female. So, actually, we got a FNAC requisition for a 45-year-old female with left retroareolar, or you can say subareolar swelling. It was just beneath the nipple areolar complex in the left breast, and the swelling was markedly painful. So the we did FNA and we got thin pus like material which was blood mixed. So around 0.5 ml we aspirated, and then we made the smear and it was stained with Giemsa and Pap stain. So here what I can focus you is when low power you can see it is a highly cellular smear, and you can see few anucleated squames also. So that creates an entire smear when we, so these small areas are there. So these all are your anucleated squames and dense inflammatory cells. Mostly it was composed of your neutrophils and bit of, in the smear you can see in the top two light blue stained cells are there. So that is your anucleated squames, and similarly it was seen in other areas also. So in this image also what you can see is dense acute and chronic inflammatory cells, predominantly neutrophils, along with your scattered lymphocytes are seen, and anucleated squames are also noted. The light bluish area with the moderate size cells. So interspersed all those areas are there. So so when we make a diagnosis of subareolar breast abscess, so what we do is we need to have mainly three, four components. Like you need to find anucleated squames in the smear, then you need to have keratin debris, and then you need to have cholesterol crystals, foamy histiocytes, and sometimes, so all these bluish area which are showing is your anucleated squames. So these four components, considering your anucleated squames, keratinous debris, then your dense neutrophilic infiltration, along with your chronic lymphocytes, chronic inflammatory cells, that is lymphocytes and plasma cells, foamy histiocytes, and sometimes cholesterol crystals. So that makes you make the diagnosis of subareolar breast abscess. That is a painful condition, but the crux point that to be noted is you have to differentiate it from inflammatory carcinoma breast. So here you need to have, if it had been an inflammatory carcinoma, we would have seen scattered pleomorphic cells also along with this dense inflammation. So that is why here, if FNAC, that has a drawback that if we aspirate only from one or two side, so what happens, we are not able to hit the malignant region if it is inflammatory carcinoma. So apart from making a cytological diagnosis, you need to have put a note that this can be a case of inflammatory carcinoma, because we are not getting ductal cells in these smears. Dense inflammation is there. So we need to have ductal cells which is showing normal morphology to say that yes, inflammatory carcinoma breast is ruled out. But if you are not getting ductal cells, so you have to put a note that you have to do a histological correlation for a definitive diagnosis. So on cytology, you can just put up as impression like cytological diagnosis is suggestive of a subareolar breast abscess, mention the left or right side breast, and then put a note. However, in few of degenerated cells and no well-defined ductal cells, we cannot rule out inflammatory carcinoma breast. So for that, we need proper histological correlation along with your clinical and radiological correlation. So that is what. So that is it's the differential. That is why important it is to know that it is a benign condition, but inflammatory carcinoma is a malignant condition. So you are giving a benign versus malignant diagnosis. So that is important for the patient's management also. So thank you so much for your patient hearing.